Hello,
Hello, Uday. How you doing?
I'm good, sir. Very nice topics today. Excellent.
Yeah, it should be a good one. Couple of presentations.
How are you, sir? You're good. I hope you're enjoying there in Miami.
Have you had any webcasts that you?
Sir, I have a case to share in this, if
Oh,
you allow.
I had the YouTube on
Okay.
at the same
I
time.
have a case.
Now, yeah, now you're in two places. You have two people in the webcast. So
Yeah.
you have a couple, right?
I have a case to share at the end of the presentation of the Basilar top.
Okay, well, at the end, touch base. Okay, yeah, you
Yeah.
should be able to.
Yeah.
I'm
Okay.
sure they'll allow you to. That's what we're here for, is interaction.
Yeah. Learn more again.
Here's the Japanese contingent.
How's the weather there?
They're here now.
How is the weather there in Miami?
I need a translator for you.
How's the weather in Miami?
I'm sorry, I didn't understand you. Could you repeat that, please?
How's the we-
Oh, here
weather in
it's
Miami?
beautiful, sunny, sunny, just like the picture.
Okay.
But now it's dark. It's still dark at 8 o'clock. Well, the sun's coming up. Good evening, Dr. Ota.
Hi, good evening, John. Hi.
How you been?
Yeah, very fine, and thank you for having me today. So, and please, Doctor Kadoka, Doctor Koizumi,
Dr.
Doctor Inoue, it's
Kaduka.
already
Good morning, Dr.
online.
Kaduka. Good evening in Japan.
Good morning, Dr. Bennett.
Good evening, Dr. Inoue.
Yeah.
Good evening. Good evening.
And Satoshi, good morning.
Good morning, good evening in Japan.
Good evening. Okay.
Hi.
We start in
Good
5
evening
minutes.
to all.
5 minutes, okay? Is everybody okay with their presentation? Do they want to practice screen sharing? Everyone okay with that?
I can practice my screen sharing. I have a case.
No, I'm talking about the speakers. Hold on. Takira, you're okay with the sharing, right? You're an expert. Everyone else okay with it? Screen sharing?
May I just try and practice sharing the screen? Sometimes my computer
Yeah,
refuses to
let's
share.
give it a shot. We've got a few minutes.
So, can you guys see it now?
Yes, perfect.
Presentation.
Yes.
Okay.
Perfect.
Okay, that's it. That's it. Thank you.
Dr. Bhatti, you there? Hello, Atta.
Good evening, Akiro, Yasuki, Satoshi.
Your
Good
camera,
evening.
your camera's not on. Your camera's not on.
Good day, good morning, afternoon. Good afternoon.
Good afternoon. So I'll introduce you, Atta, and then you introduce, I guess, Takira, okay?
Sure.
And you guys will be monitoring. Takira, you will be monitoring, okay?
Workflow, what we follow in this session. So after your introduction, I'll briefly introduce Akiro Ota, and then he will take over for.
Okay, you can do what you want after I introduce you.
So,
Free now.
Mr. Ota, is that fine if I introduce you, or you can introduce yourself? So you start with that.
So you like broadcasting, Takahiro?
Yes.
You
So
like
after
you like to broadcast?
yes, after your introduction, John, I will give a small talk at the initial talk.
Sure, yeah, I'm going to
Okay.
introduce Atta and then he'll introduce you and then you can do what you want. That's the way you have it
Okay.
planned, right, Atta?
Yeah, sure.
No problem.
2 minutes. Lines. So what is it now? Summertime in Japan? Is it opposite seasons? Like right here, it's summer, not summer, it's
It's the start of winter.
getting, yeah,
Yeah,
Christmas
it's,
time, obviously.
yeah, it's getting very cold these days.
Oh, it is cold. That's the cold part of the year. It was Christmas time. Okay, 1 minute. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, this is Dr. John Bennett broadcasting from Miami Beach here in Florida. We have the honor of having another Japanese dual neurosurgery webcast, and I'll introduce the neurosurgeon that's affiliated with our channel, our dual neurosurgery channel, Atta Bhatti, neurosurgeon from Pakistan, currently in Switzerland. Good morning, Atta.
Good morning, John. Let me just hand over the session to Professor Takahiro Ota, who is a Japanese neurosurgeon and chief of neurosurgery and neurointervention Tokyo Metropolitan Center. He is well known and well visible on various educational sessions and seminars on international forums with a lot of academic experience and very close friend. Let me just hand over it to Professor Ota.
Okay, good morning and good evening, everyone. And today is the second dual neurosurgery program on Japanese neurosurgeons, and it's a great honor to co-chair this very special program with Atta. And today's topic is basilar tip aneurysm. And basilar tip aneurysm is now predominantly treated by endovascular techniques. There is a complete reversal from when I was first learned surgical techniques about 20 years ago. However, I believe that clipping and coiling embolization should not be competitive. Well, most agree that endovascular treatment of basilar tip aneurysm offer advantages in most cases, but this does not mean the clipping surgery should be neglected. On the contrary, in this endovascular era, understanding the strengths and limitation of microsurgical clipping is essential for us for achieving better patient outcomes, I believe. So, listening to today's lectures by two Japanese neurosurgeons will undoubtedly give us very useful information to treat the patient with basilar tip aneurysm. Now then, let's get started. I will introduce our first speaker, Dr. Satoshi Koizumi, and Assistant Professor, Department of Neurosurgery, the University of Tokyo Hospital. He is a chief in intervention neuroradiology, and he is very aggressive and passionate in educating young neurosurgeons. So, Dr. Koizumi, could you start your lecture?
Thank you, Dr. Ota. Thank you for your introduction. So I will start my lecture. Can you see my slide?
Yeah, but yeah, okay.
I think it's okay. So let me start my lecture about basilar artery and its perforators. So my name is Satoshi Koizumi. I'm from the University of Tokyo Hospital, Department of Neurosurgery. So today I will talk about two contents. One is basilar tip, and afterwards I will talk a little bit about the basilar trunk of aneurysm perforators. And I will talk about a little bit about basic anatomy, and afterwards I will talk about clinical implication of those anatomical knowledges to practical treatment of unruptured intracranial aneurysm. So for one, basilar tip. So I start my cases with from AIS case. The patient is 55-year-old male who complained dizziness, but afterwards he gradually fell down, lost consciousness. On arrival, his GCS was E1V1M1 with pupils dilated at the left side. On plain CT, we can already see that the hyperdense sign in his basilar tip. So this is his CTA. As expected, there's a contrast defect at his basilar tip. So we go on, we took him to angio suite and start thrombectomy. This is the initial angiography. So onset the puncture was 145 minutes. This is after I put 8 French guiding catheter here. For basilar tip, I usually perform aspiration thrombectomy. As usual, I put aspiration catheter at the occlusion site, and TC2B recanalization could be achieved. I think there's some residual thrombus here. So we judge that it's 2B. And offset to recanalization was 165 millimeter. And here, I want to show you about the diffusion imaging. So as expected, as you can see, there's more evident ischemia at his cerebral hemisphere. But I want you to focus on here. Bilateral thalamus and the tectal portion of the midbrain is damaged. The damaging area is more evident on coronal view. Here we can see that the bilateral thalamus and the bilateral midbrain, paramedian part, at the upper part, tectal part, is damaged. And what about his functional outcome? His modified ranking scale at 3 months was 2. His consciousness gradually recovered. In 1 month, his consciousness recovered completely, but his ophthalmoplegia and ptosis persisted bilaterally. So he had to get plastic surgery to lift up her bilateral eyelid. But now he returned to work normally. So this case shows the functional anatomy of here, the basilar tip perforator quite well. So let's focus on here. So the most functionally, the most important and most famous basilar tip perforator is called posterior thalamoperforating artery, PTA, or it is also known as paramedian thalamic arteries. It arises from P1, usually bilaterally. So as shown in this figure, the right side PTA supplies right side thalams, and the left side PTA supplies left thalams. And they penetrate anterior part of posterior perforated substance and feeds medial thalamus. So this is the superimposed image of the 3D array and coronary image T2. What about the midbrain perforators? The midbrain perforators are called superior and inferior paramedian mesencephalic arteries, and they penetrate posterior part of posterior perforated substance. So posterior perforated substance, anterior half are there's thalamic perforator, and posterior half midbrain perforators. So the relationship between those perforators is clearly visible in such a sagittal schema. Sagittal view, we can discriminate those branches quite well. And I go back to PTA origin, which is this is a famous and classic Percheron's classification. So the most most frequent type is type 1. As I explained earlier, right side supplies right side thalams and the left side supplies left side thalams. However, in some cases, there are two PTAs coming from the one side, in this figure, right side. And in some cases, some extreme cases, one common trunk supplies bilateral thalams. This is called artery of Percheron, so-called artery of Percheron. And the incidence of artery of Percheron ranges from 7 to 26%. In cadaveric studies, the percentage is around 10%. However, in radiological studies, the incidence of Percheron artery is reported to rise up to a quarter, 25% or something like that. And in some extreme cases, just some anastomotic or arcade-like vessels which give rise to bilateral Percheron artery. For considering basilar tip anatomy, this classic schema is very quite useful in the understanding. So as you probably know, it's phylogenical stage. The basilar artery fuses. Basilar arteries are composed of the fusion of two longitudinal arteries. When the fusion is not complete at the upper ring, at their tip, the fusion is called symmetrical caudal fusion. In such cases, bilateral SCA arises from the P1 segment. And if the fusion is complete, bilateral SCA is coming from the basilar trunk itself. In such cases, they are called symmetrical cranial fusion. And in such cases, one side caudal and one side cranial fusion. They are called asymmetrical fusion. And in functional anatomy, we have to understand the PTA distribution in asymmetrical fusion. In asymmetrical fusion pattern, dominant PTA usually arises from cranial fusion side, in this figure, right side, and supplies bilateral thalams. In many cases, non-dominant P1 perforators usually midbrain branches. So functionally, P1 perforator from the cranial fusion side is more important. So this is my case. This is the patient is 79-year-old female who had ruptured basilar tip aneurysm around 5 millimeter in its side. In this patient, right side SCA is coming from the proximal part of P1, and the left side SCA is coming from the basilar trunk itself, and there's a duplication of SCA. So this case can be called asymmetrical fusion. And in cases of asymmetrical fusion, the aneurysmal neck predominantly involves the caudal fusion P1 side, contralateral to the cranial fusion side with dominant PTAs. In this case, we can also see the PTA, posterior artery, supplying bilateral thalamus like this, like this, like this, like this. So in such cases, we don't have, in this case, when protecting neck, we don't have to take care so much about the protection of PTA because the PTA is on the opposite side of the dominant neck side. So in this case, we use the balloon remodeling technique to create a neck of the aneurysm and perform simple coiling. The procedure was successfully performed, and the patient recovered quite well, and the patient is recurrence-free for 2.5 years after the procedure. So again, I go back to the theme of today's lecture. So P1 perforator visualization in 3D array in a real practical case of unruptured intracranial aneurysm. This is a patient with unruptured basilar tip aneurysm. In this case, symmetrical caudal fusion. This is AP view and this is PA view. We can see perforator coming from around here and around here. Let's see the details of this patient. This is a MIP view. I think the speed of the movie is quite high, so I stopped the image. Sorry. This is AP view. So here, the dominant PTS originates. It rises up like this, like this, like this. And here it bifurcates to feed bilateral terms. And for the left side, for the right side, here, the perforator starts from here. In fact, it starts not from P1 and it starts from the proximal part of the SCA. And when we see, it's quite a bit difficult to understand in the coronal view, but in the sagittal view, in this SCA perforator, it's evident that its SCA perforator feeds midbrain. I will show you the sagittal images afterwards. So again, let's go back to the treatment of this case. The size of the aneurysm is around 5 millimeter. In fact, it's getting larger during outpatient clinic imaging follow-up. So we decided to treat him. But the treatment is quite simple. We used web device. In the selection of web device, it's quite important to select the size wide enough, a little bit, approximately 1 millimeter larger in the measured compared to the measured length of the aneurysm. The device should be larger, more wider. And the position of the device to the aneurysm is quite good on high resolution cone beam CT. This is the final run. The contrast residual feeling is quite good, and here in double shadow we can see the running of the left side PTA quite nicely. But the configuration of the P1 perforator is more evident when we analyze the follow-up images. This is the angiography at 1 year. We can see that the device is a little bit device deformation, but the aneurysm has almost disappeared. There's only a tiny contrast feeling, residual contrast feeling at the neck. but I think the result is satisfactory. And this is the 3D array at the follow-up angiography. In this view, we can see that the configuration of the spatial relationship between the device and the P1 perforator. So the P1 perforator is running just the posterior part, posterior wall adjacent to the posterior wall of the aneurysm. It's evident. So so this is the MIP view, coronal and sagittal. In this sagittal view, it's clear the relationship between the thalamus perforator and midbrain perforator. So I wanted to show you that those perforator can be visible in real cases, in practical cases. And understanding the anatomy of those perforator is quite important in considering the treatment. So now I'll talk about a little bit about the basilar trunk perforator and the unruptured intracranial aneurysm, especially for flow diverter treatment. Now I start from the cases. The patient is 79-year-old female, basilar tip large unruptured aneurysm, treated firstly with stent-assisted coiling from left side PCA to mid-basilar. But the aneurysm recurred at the right side P1 side, so I put a second stent, and we performed the combination stenting, T-stenting, and additional coiling. The immediate result was quite good. The post-operative course was uneventful. However, 2.5 years after the second treatment, the patient suddenly developed dysarthria and left side hemiparesis. So this is the diffusion images and the T2 images. So there's a paramedian midbrain ischemia only at the right side, hemilateral, unilateral ischemia. And in these T2 images, we can see the right side P1, and this is the neck of the aneurysm. And I think this is the marker of the stent, neurofilm atlas, in fact. I think it's the ischemia of the jailed basilar trunk perforator. Sorry. So now when we understand the perforator anatomy of basilar artery, it's important to notice its homology to perforator of the spinal artery. So the homology of the brain stem and spine is quite important. So in basilar artery, the direct perforator is homologous to sulcocommissural artery of the anterior spinal artery. And the transverse pontine artery, they are homologous to coronary artery of the spine. And those transverse pontine artery, when they have well developed and feed also a cerebral hemisphere, they are called ICA or SCA. And in some cases, especially if the chronic occlusion of the basilar artery happens for any reason, there may be an anastomotic longitudinal channel between those hemispheric perforators. In 3D array or in high-resolution cone-beam CT, we can see those perforators quite well. And those images are cited from neuroangio.org. So we can see those perforators quite well in created images. But for these visualizations practically useful in real practical treatment, for example, flow diverter, I will show you some cases. So this is 30-year-old female who have upper basilar trunk thrombosed aneurysm. we can see the P1 perforator beautifully like this in these high resolution whole beam CT images. But now I want to focus on pontine artery, pontine perforator here, which is visible also in 2D images and 3D images. For this patient, I put 2 microcatheters to treat her. One at PCA, left side PCA, and one at the aneurysm. And from the P2 catheter, I put flow diverter like this. This is the high resolution whole beam CT just after the placement of flow diverter. As you can see, there's pontine perforator visible around here and here. And we can see that the apposition of the flow diverter stent and the arterial hole giving rise to those perforators is quite good. There's no gap between the perforator and the device. We can see that the apposition of the device and the P1 perforator is quite good in this image. After I confirm that the flow diverter position is okay, we put some coils inside the aneurysms and the treatment is complete. So the post-operative course is uneventful. The patient developed no symptom at all, and the patient recovered, and the patient was discharged unevent-free. This is 1 year follow-up. There's some residual contrast feeling around her neck, so we judged that it's OKMB. But at this stage, we didn't decide to add some additional treatment. So we still continue her under close follow-up, close imaging follow-up at outpatient clinic. So this is the 3D array at the follow-up, 1 year follow-up 3D array. Again, we can see the patency of the pontine perforator quite well, and we can see the patency of the PTA quite well. This PTA is symmetrical one, type A, at Parson's classification. Again, on the sagittal view, we can see both the thalamic perforator and midbrain perforators. So I want to focus on this case is that the basilar trunk perforator is, the patency of those perforator is persisted if the device is attached to the position of the device and the perforator is okay. The patency of those perforator is good, and the result of ischemic complication, the risk of ischemic complication can be quite low. So how about in this case? This case is 59-year-old male who had vertebral junction giant thrombosed aneurysms with mass effect. The patient already developed progressive dysphagia, so the treatment was necessary, we judged. The thrombosed aneurysm compressed his midbrain, his brainstem. This is 3D array. In this 3D array, we can already see some small vessels coming from the dolichoectasic part of the aneurysm, which is shown in like this. In fact, this perforator is coming from the junctional area of the normal caliber basilar artery, upper basilar artery, and the dolichoectasic aneurysm. In the paper, it is reported that the pontine perforator is usually absent in those dolichoectasic aneurysms. As shown in this figure, the blood supply to pons is supplied by the blood flow to pons is taken over by another perforator coming from superiorly or inferiorly. This is the case. This is case of the images, high resolution whole beam CT, sagittal one. As you can see here, we can we can see that the many perforators are running vertically to the from the upper BA. But here we cannot see so much the perforator flow directly from the dolichoectatic aneurysm at all. So the blood supply to the pons is reported to coming from the upper side or lower side, normal portion of the basilar artery or vertebral artery. So again, we decided to treat him with flow diverter stenting, multiple flow diverter stenting in a telescopic fashion. So in such cases, to keep the patency of the perforators, it's quite important to put the appropriate diameter of the flow diverter. So the distal part and the proximal part, the diameter is around 4 millimeter, and the estimated total length of the flow diverter placement is calculated about 80 millimeter, 8 centimeter. So if we decide to treat him, the treatment was technically quite simple. The navigation of the microcatheter to the P2 portion, or left side P2 portion, was quite simple. And we put flow diverter in a sequential fashion. So first we put 4 millimeter pipeline sealed, longest one. In its placement, I took care not to put this flow diverter in the upper basilar artery too much to avoid occlusion of those perforators coming from the upper basilar artery. And once I put one flow diverter, I have to continue putting another flow diverter up until the normal vertebral artery. So I size up 4.25 millimeter, longest one, and the third one was the same one, and the fourth one, 4.25 millimeter. So as a result, I put 4 flow diverter in a sequential fashion. So this is the final angiography, 3D array and 2D. So the post-operative course was again quite good. The patient does not develop any new symptom clinically or radiologically. However, the patient's dysphagia did not improve so much just after the treatment. This is the 3D array just after the treatment. This is the slab MIP, and this is the actual view. And I want to show you is this part. So this part, there's some residual perforators at the junction of the upper part of the aneurysm and the normal basilar artery like this. And for this perforator, there's some gap between the perforator itself and the device. So the position of the flow diverter device is not perfect in this case. So it's already reported that the relationship of the aneurysm and those perforator is quite important in estimating the occlusion status during the follow-up. This report is written by my colleague, Dr. Fujitani. He's surveying the occlusion status about the anterior circulation aneurysm, especially ophthalmic aneurysms. And they concluded that the important point is to isolate the aneurysm from the adjacent smaller branches. In this case, ophthalmic artery for most cases. If the aneurysm is isolated from the adjacent perforators, the occlusion could be expected. But if not, the persistent filling of the aneurysm is expected. So in this case, also for the posterior circulation and small perforators, those non-isolated branches can be a risk factor for incomplete occlusion, I suppose. So I suspect that the aneurysm could not achieve complete occlusion. So this is the 5 months follow-up angiography. There's some residual contrast feeling in the lower part and the upper part of the aneurysms. But I think the result was satisfactory. But when we see this image quite well in the 3D array, so here we can see the pontine perforator are coming from the upper side of basilar artery. But here we can see again there's some perforator left from the residual part of the contrast feeling. So the reason that this part could not be occluded after flow diversion is that there's a perforator, I suppose. And the result of this patient was not satisfactory at all. Half a year, 6 months after the follow-up angiography, the patient suddenly lost coma. The patient suddenly lost his consciousness and taken to our department. The patient had subarachnoid hemorrhage, and on angiography, the flow diverter was completely occluded. On angiography, we can see the anastomosis between the pica and the SDA like this, but it is not adequate at all. The patient had total ischemia at his posterior circulation. So his final modified ranking status was 5. However, I considered again and again, how can I improve the functional status? How can I change the results of this patient? Honestly, I have no idea. Putting more flow diverter, additional treatment, telescopic fashion flow diverter, or adjunctive coiling at any extent, I have no idea at all. So this is the summary of my today's lecture. The current high-resolution cone beam CT or 3D array can visualize the basilar artery perforators quite well. The P1 perforators supply thalamus and midbrain, which is quite functionally important. And the patient's patency of Passion's artery is essential in basilar artery tip aneurysm treatment. So the important thing is to notice the presence of Passion's artery or PTA. Basilar trunk perforator visualization may be or may not be useful in the treatment of basilar trunk aneurysm with flow diverter. This is the last slide. If you are interested in today's my topic, I strongly recommend to read this article, which is recently published in JNIS, written by Ethan Last. This article really has nice images, so must read, I think. That's all. Thank you.
Thank you for your excellent lecture, Dr. Koizumi. So I thought it's time for discussion for Dr. Koizumi's presentation. Okay.
I think we would go for question answer sessions after the second talk.
Okay.
That's my suggestion.
Okay.
Yeah. Or yeah, that's what the plan is.
So, Dr. Kadoka, could you chair the second session?
Okay, thank you. Okay, let's move on to the next presentation. Good morning and good evening in Japan. And I'm Dr. Keisuke Kadoka from Kameda Medical Center. The next speaker is Dr. Yasuaki Inoue. He's the chief of the Department of Neurosurgery at Nadogaya Hospital in Japan. And he's a leading hybrid neurosurgeon with extensive experience in cerebrovascular surgery and is widely recognized for his expertise in microsurgical treatment of complex aneurysms. Today, he will share his experience with microsurgical clipping of basilar tip aneurysm. Dr. Inoue, please start your presentation. Thank you.
Okay, sure. Thank you, Professor Kadoka. Okay, can you see my screen?
Perfect,
Yes.
perfect.
Okay, good. Okay, ladies and gentlemen, I'm Dr. Inoue from Japan, and today I'm going to talk about the microsurgical clipping of distal basilar aneurysms after all the lectures covered by Professor Koizumi on topics of anatomy and also the endovascular techniques. So I'm gonna solely focus on the clippings of the aneurysms in the distal basilar area. Now, since my becoming the chair of the department in 2021 at my hospital, I treated close to 300 cases of aneurysms, and half of them are ruptured and half of them are unruptured. And I personally do both endovascular and clipping as well. And these are the numbers. And today I'm going to talk on the topic of the ruptured aneurysm in the basilar artery area. And in my hospital, we have a protocol that the craniotomy surgery is the first-line treatment for all the ruptured aneurysms. So I'm going to talk a little bit about the reason why. And during this period, maybe the number might be different. During this period, I treated close to 130 ruptured sacral aneurysms, and then most of them are, close to 80% are treated cranially. And this is my protocol. So whenever we get a cerebral hemorrhage patient, we get a creatinine rapid test, and immediately after that, we get the CT scan or CTV to exclude other etiology. And when we diagnose that the patient has the ruptured aneurysm as an etiology of the cerebral hemorrhage, then most of the time we bring the patient to the angio suite to do some angiography to see, diagnose fully or see the morphology or even the anatomical structure of the perforators. But if the clipping is feasible in my facility, we do craniotomy. The reason is, so I'm gonna skip the details of the talk information. But the main advantage of doing the clipping of the aneurysm is we can remove all the cerebral clot. So personally, we've almost never experienced a vasospasm after cerebral hemorrhage. So these are the numbers in my facility. So close to half of the cerebral hemorrhage patients were transferred to my place with a severe grade, even grade 4 or 5 patients were treated. But I'm kind of proud of the numbers. I'm not satisfied, a little bit proud of the numbers because exceeding the half of the numbers are, returning home walkie-talkie with modified ranking 0 to 2. So the main reason why we're going to clip the ruptured aneurysm is to remove the clot. So we're going to clot to avoid, prevent the vasospasm. So anyways, since my residency, I counted the numbers of the aneurysm clipping of the ruptured basilar distal basilar aneurysms, and which I performed kind of independently. Now I experienced actually only 9 cases of this ruptured distal basilar aneurysms, but I clipped 8 of them. So I brought in total 5 cases to show, and I'm gonna start with the basilar SCA, not the basilar tip, to show the concept of the access to this area. So this is kind of my memorable case because I got this, this is my first case of accessing the ruptured basilar distal basilar aneurysm. I was kind of scared because the aneurysm may look like a, basilar tip, but in reality it was a basilar SCA. And then this is a final picture of the CT CAT scan. And most of the time, if the aneurysm is high enough, located high enough, then we may have to do the transdiagrammatic approach. And the craniotomy might be a little bit broad because we may have to do anterior temporal, what is called a Transylvian approach, along with the subtemporal approach. Essentially enough, although the patient was transferred to my place with WFNS grade 4, the patient was discharged home, walkie-talkie with modified ranking 0. I was kind of, rough to clip the other side as well. Anyways, so I'm gonna talk about my memories of my treating the basilar tip aneurysms. The first case was transferred to my place 2 months after my first case of basilar SCA aneurysm. And sadly, this patient experienced 2 ruptured presumably ruptured episodes, was transferred to a kind of a very famous emergency center close to my place, but was overlooked twice. And then came to my place in the third time, and then we got the CAT scan, which demonstrated a cerebral hemorrhage with ruptured basilar tip aneurysm here. And on the tip, probably this is the ruptured point, but anyways, we went to a craniotomy. So this is most of the times I remove the anterior clinoid process extradually, so we can move the carotid artery more aggressively. And this is a distal transfer approach. And this is my case during my residency. So there are a couple of technical issues. Anyways, so this is here you can see the tentorium, and this is the oculomotor nerve. This is the right side approach. This is the uncus, temporal uncus, and this is the anterior carotid artery, anterior PCOM artery. This is a posterior cranial process. Since the aneurysm was located very low, I decided to dissect the inside the tentorium as well. And now I'm trying to find a trochlear nerve, a cranial nerve number 4. Here you can see a trochlear nerve behind the tentorium. And this was SCA here. Now here I'm opening the tentorium after cauterizing the draw sinus. And now I'm also cauterizing the posterior clinoid process to shrink it a little, to widen this corridor. But this was kind of scary because, even with this procedure, the proximal contour was not enough. And here you can see that the very important perforator in the vicinity of the neck. But I could not fully expose the interior aspects of the aneurysm, so I decided to tentatively clip the dome of the aneurysm. This was the moment when it ruptured. So it was a very scary moment. But the reason why I did not, completely clip the neck of the aneurysm was, so I wanted to dissect the perforator behind the aneurysm. So if we lose any of this tiny perforator, the patient will get into the locked-in syndrome. See that and this is a rupture point. But anyways, I want to show you that when I'm closing up the aneurysm, this is the only moment that we can see the entire aspect of the tiny perforators behind the aneurysm. You can see that there's a perforators coming from the other side of an aneurysm as well. So the reason why I wanted to show you this video is that only at the moment when we slowly closing up the aneurysm, that we can see the other side of the aneurysm to locate the important perforators. So this is IC green video angiography to illuminate the perforators, and I utilize fluorescein angiography as well to really make sure that all the perforators are patent. And this is the final picture. So since I utilize a subtemporal approach as well, along with this transverse approach, I did a very big, huge craniotomy for this case. But since the patient was presented with a lower grade, thankfully, the patient was discharged home with modified ranking 0. And I'm going to show you not the basilar tip, but the basilar SCA case. This is kind of an interesting case. Well, actually, this is a very memorable case because I was, mentally broken because of the family issue. But this is a moment when this cerebral hemorrhage case was transferred to my place from the other outside hospital due to inability to treat. And this is a thick cerebral hemorrhage with a ruptured right basilar SCA aneurysm. Again, for all the cases, I removed the anterior clinoid process extradually to maximize the mobility of the internal carotid artery. Here we can see there's a marker. Here we can see the C2 segment of the ICA. And this is a right side approach again. And then this is ICA. Here's a tentorium. And this is a posterior clinoid process. And now I'm incising the lilicus membrane. And here's an oculomotor nerve here, which is tightly attached to the rupture point of the aneurysm. The reason why I wanted to show you this video is that, so here you can see the important perforator. I'm gonna repeat the video again. Now I'm dissecting the neck of the aneurysm. But here you can see the basilar tip perforators. But although the basilar SC aneurysm located very close to the basilar tip aneurysm, there's no important perforator coming from this location. So the clipping is comparatively very easy. Still, I'm making sure that I'm not pinching something important behind, and adding another fenestrated clip to make sure that all the necks is closed. So this is a very basics of the basilar SC aneurysm clipping. Now, although the patient was transferred with a severe grade, thankfully patient was discharged home with a good grade. But you see that a little bit of a temporal tip got a little bit of a venous infection, probably because of the extensive retraction to access the narrow corridor down to the basilar SCA area. And my next case will be my case during my PGI 7 year. It was a basilar tip again. And this patient had probably one case of cerebrovascular hemorrhage, which was, twice, basilar PCOM, which was coiled, and MCA, which was clipped. So you can see that apparently something is happening here. And then the premorbid modified ranking scale was not that good. But since a family member requested a treatment, we went to the OR to clip this tiny basilar tip aneurysm. It's difficult to distinguish, but if you see this aspect, you can see the aneurysm anteriorly projecting aneurysm. If the basilar tip aneurysm is anteriorly projecting, the clipping will be very easy because there's usually no perforator anteriorly. After removing the client process, I'm accessing from the right side again, because this side was healthy, easy to open. I'm shrinking the dura mater on the posterior cranial process. I was probably, I would say, too confident to access this area. This is a P1, so here there should be an aneurysm, but I was too aggressive and it ruptured, premature ruptured. But what was worse about this case was, so since the aneurysm was located very low and I was not opening a subtemporal approach, I was not having the access to the proximal control. I placed glue to compress, apply some compression to achieve some hemostasis. And here is the aneurysm. Thankfully, the rupture was easily stopped. Again, there's no perforator on the anterior aspects of the basilar tip aneurysm, so the clipping was very simple. But still, you see that the important perforator is located very close to the aneurysm. So again, before the clipping of the aneurysm, it is really difficult to fully visualize all the important perforators, which can be only visible at the moment when you are slowly closing up the aneurysm to make the space here. So simultaneously, while you are closing up the neck of the aneurysm, you have to visualize and avoid, dissect somehow the perforator, so it is not pinched by the clip. Anyways, this is the pictures. Again, there are kind of diffusion high areas in the MRI. And this is also very kind of educational thing, because at this moment I was more or less like endovascular treatment is okay for the cerebrovascular hemorrhage, and this was New Year's Day 2 years ago, and this patient was poor man was transferred to my place from a very famous outside hospital where a very famous endovascular neurosurgeon is working active. But he called me actually personally to treat this patient because they suppose that this aneurysm might not be kind of coilable or not be treated endovascularly. So as per his request, I brought the patient, opened the OR in the New Year's Day, and to brought the patient to the to the OR. And this is a cranialomy after transdiagrammatic approach. This is the anterior colonnade process removal, extradually. And this is a distal transsylvian approach. I'm going to skip this part a little. At this moment, I selected the left side approach so I can see all the perforators in the vicinity of the aneurysm. And this is the M1 segment. And this is the perforator coming from the M1 segment to the temporal lobe. And this is a very important aspect of the anterior temporal approach to access the basilar tip area. So this corridor, this is the anterior corridor artery. So we emphasize that this M1 segment temporal lobe, this triangle is very important for you to freely manipulate this deep area, narrow corridor. This is a ruptured aneurysm. What it was scary, this is the ruptured point. You see that there's some, scar tissue on it. And then since the PCOM artery was in the way of our manipulation, I decided to ligate it in contrast and cut it to make the corridor there. But again, what was scary was that so ruptured point was not on top of the bigger saccular area, but on top of the very tiny, not aneurysmal area. So this is more or less like a dissective or weird disease, rather than we call it saccular aneurysm. Again, here you see a perforator. So actually, it took more or less 2 hours to dissect all the perforators, which was tightly attached to the aneurysm in this case. And thankfully, he's now coming to my clinic once a year. But again, we got some infections on the temporal lobe and also on the anterior corridor artery, sadly. But luckily enough, the patient did not get any symptom coming from this anterior corridor artery infarction. So now we can say that 3 months after the clipping, the patient is now modified ranking scale 0. And I prepared another case in case we got spare time. So this is not truly a clipping of the aneurysm, but this is a ruptured, previously ruptured basilar tip aneurysm, which was called by another neurosurgeon outside the hospital. Actually, this poor lady got 3 episodes of cerebrocanal hemorrhages, and this is a 3rd episode. And here is a coil mass, and actually the neck was kind of broad, and which recurred. I mean, it was growing up steadily, and then she requested me to clip it. But I was supposing that clipping was not feasible because usually after that intensive coiling, the coil mass will be tightly attached to the brainstem. So I extensively spoke with the patient, and we got the plan that we first plan will be try to clip it, but if not feasible, I will drop a bypass so we can create a corridor for stent coiling, horizontal stent and coiling. Since the patient got the 3 episodes of the cerebrocanal hemorrhage, the brain, sylvian fissure was very tight. The never, which was sharply incised and open. I'm gonna skip this area. Anyways, this is a basilar tip aneurysm. Here you can see the perforator, and here is a coil mass. But you can see that although I tried to pull down the aneurysm, but which was tightly attached to the brainstem and could not move it. And here is the neck. And close to the neck, also you can see that some coil is coming close to the neck of the aneurysm, which means that I could not apply clip here. But our plan was to try to place a stent coil, but actually initially the patient refused because she was not trusting the endovascular treatment because it recurred, and she wanted to. She asked me to do something, cranially. So I decided to do a STA-P2 bypass. Actually, I got the consent for this plan B as well, preoperatively, and I placed a STA-P2 bypass. This is a deep corridor, narrow bypass. I dropped 20 stitches all around. Let's skip this area. Now ICG video angiography, comfort the patency. And immediately after the surgery, I brought the patient to the angio suite and cannulated the STA, which was illuminating the PCOM, not PCOM, P2 and distally. And from this STA, I'm gonna skip this area. From this STA, I cannulated right P1 basilar tip and two left P1, P2. So I placed a neurohormone atlas stent to drop some coils. We suppose that a horizontal stent is more reliable to treat the aneurysm. Anyways, I dropped more coils, and it worked very well. And now the patient is visiting my place. No recurrence anymore. The patient is happy. Okay, this is my summary of the presentation. So actually, there's no technical thing today, but I just wanted to, show you how we clip it or how we access the area. And then I would say this is kind of a memory of my residency, but most of the ruptured distal basilar aneurysm will tend to be referred from outside hospitals. And then for all the cases, required my full extent of my surgical skills, and inevitably, which was tightly tied to the my emotions and memories at that particular moment. This is my interpretation. Thank you so much. Thank you.
Thank you for your excellent lecture. And Dr. Atta, shall we start the question and answer session for both lectures?
Yes, sure, please. Floor is open for questions and
Any
comments,
questions?
please.
Can I share my case also?
Yeah, sure, you can. Dr. Uday has
Let's take the questions now, Uday. You can do it at the end, okay?
Okay, sure.
Okay.
Yeah. Okay, questions for either of the two talks, please? Or comments? We can start with you, Atta.
Yeah, both presentations were excellent. So it covers almost all the details of all complexities. Since we know that it's posterior circulation is not an easy place. You need a precision. You need a very much surety before you clip or coil. So congratulations for both excellent presentations. And I think I like the number and approach given by both the speakers. And I think in ruptured cases, the results were excellent. Dr. Yasuke, what is your strategy in unruptured cases in Basilar?
Okay, thank you for the question. Actually, for most of the unruptured cases of a basilar tip, actually, almost all the cases are treated by endovascular, like web, stent coil, or even simple coiling. It should be the best option, I guess.
Right. Despite all the expanding options in hand in endovascular arm, like starting from the simple coilings, then assisted coilings, whether it's stent or balloon assistance, then the more metallic options like the Baby Leo, Piconus, flow diverters. One thing is for sure that basic is important. So I remember Dr. Reni Shepo from Essen was presenting the complex cases after the coiling. So the responsibility of microsurgery is expanding. Don't you think that the demand microsurgery is becoming more demanding in the era of endovascular? So
Yeah, I would say yes. I would say yes. Actually, so after the coiling, if the patient is not happy with getting another treatment, and vascularly, most of the times the patient will Google the locations where they can get the treatment, like bypass, the trap, the lesion. So some of cases are kind of referred to my place, not frequently, but more often. And then most of cases are getting more complex, like the case I showed, the basilar tip aneurysm. And also, what is challenging to me is like the case of the failure case after placing the flow diverters. For sure, after flow diverter, we may have to do a very tricky bypass to get blood supply to this area to treat the lesion. So in this era of the endovascular treatment, we've got to say direct surgery is getting more challenging.
yes, I come back to Dr. Satoshi Kozimi. He has excellently demonstrated perforators. I did miss one component, the importance of circulation and PCOM, and after the treatment, the establishment of circulation paradigm to a new normal. Dr. Satoshi, can you please comment on that PCOM importance? Because at times PCOM may not be visible before the treatment, but it is involved. We get different flow patterns. So what are your
Yeah, thank you for your important point. So of course, if the patient has sufficient PCOM and both sufficient PCOM and P1, we can sacrifice the shoulder of the aneurysm on that part. So in such cases, the important thing is to preserve the blood flow retrogradely coming from the PCOM to the P1 perforator. So it often ends if we sacrifice the shoulder of the P1, if we interfere the antegrade flow from the basilar artery to the PCA, the perforator flow can become retrograde in some cases. In such cases, there's a possibility that the perforator ischemia can occur. So we have to take enough care. For example, continuing anticoagulation for heparin for 2 days or 3 days, something like that, especially for unruptured cases.
Okay, Dr. Takehiro, Professor.
Yeah, now I have one question to Dr. Koizumi. Which aneurysm in the posterior circulation do you refer to your counterpart surgeon for microsurgery?
Yeah, so one is wide neck aneurysm, of course, but due to the because of the development of the devices, I think the endovascular treatment, the indication of endovascular treatment is enlarging even for wide neck aneurysms. But one problem which remains for endovascular treatment is small aneurysm, I suppose. So in basilar artery or basilar STA aneurysm, for subarachnoid hemorrhage especially, one subtypes of aneurysm is called perforator aneurysm, or which can sometimes be a cause for perimesencephalic type SH. So in 1 week, 2 weeks afterwards, the tiny aneurysms develop at the basilar tip or the basilar STA. In such cases, the treatment with coiling can be quite difficult. And in such cases, I ask my colleague, my senior colleague, neurosurgeon, to perform craniotomy.
Okay, so yeah, in Japan, flow diverter stent in acute stage are not available. But if we can use the small some less thrombogenic flow diverter can be used. The aneurysm which you mentioned, small basilar trunk aneurysm or basilar perforator aneurysms can be treated with the flow diverter, I think, in the near future.
Okay,
May I ask?
yeah, sure, please.
Thank you. Dr. Koizumi, thank you for your excellent presentation. And my question is about the cranial and caudal fusion of PCA. And is the differentiation between cranial fusion and the caudal fusion primarily based on morphology like this, or is it defined by whether the superior cerebral artery SCA originates from the posterior cerebral artery? I want to know the definition of cranial and caudal fusion. It is determined by the morphology or origin position of SCA.
Yeah, during reviewing the original paper by Dr. Campos, I had the same question with you. So I'm not. So I have no definite answer for your question, but yeah, but I think I think the cranial fusion and distal fusion is not a digital one. So there's some transitional area as shown in my slides. So the SCA bifurcation point is just a threshold, I think.
Thank you. I will start with reading that paper. Thank you.
So, despite a perfect job during endovascular, we may see surprises in the follow-up, whether it be a compaction in coiling or dislocation of the flow diverter or recanalization or lateral canalization. So I was just referring Shepo's remarks that sometimes it becomes all the tools becomes rubbish inside the river like situation. So the challenge associated with all the endovascular tool is requirement of antiplatelets or anticoagulants. So what is your strategy and routine for that? Do you do testing before the procedure for the sensitivity and
Yes.
effectiveness?
Yes,
Okay.
yes. So our regular dual antiplatelet therapy with aspirin and clopidogrel, 100 milligram and 75 milligram, and we perform platelet testing around one week before the treatment. And in Japan, there are some patients are hyperresponsive. Some patients have hyperresponsiveness to clopidogrel. In such cases, we switch to FN plus grel. Yeah, so I think in East Asian countries, the platelet function testing is really essential, I suppose.
Thank you. Dr. Tahiro and Dr. Kaduka, do you have any comments on that point? Please.
About the antiplatelet therapy?
Yes, especially in ruptured situations.
Ruptured.
Ruptured.
Yeah.
In ruptured cases, in our institution, we don't prefer to add any antiplatelet therapy. We will perform the endovascular treatment without antiplatelet agent, only with heparin during the procedure. Yes.
What should be done in cases of non-responders to clopidogrel?
Sorry,
Non-responders. Uh, the
I,
non-responder to clop.
ah, unfortunately, in our hospital, we can't check the antiplatelet, sorry, non-responder. We cannot check. So we prefer to use not clopidogrel, but prasugrel.
Prasugrel, yes.
Yes.
But I was that the thing which I wanted to ask was in case if the patient presents with hematoma and we need to take him for surgery after an endovascular treatment in the same setting, and so how we'll manage the anticoagulation pre and post procedures.
Uh, we have few cases which needs endovascular treatment and open surgery at the same time. In such cases, we prefer the direct surgery and hematoma removal and clipping
Okay.
in one session.
Can I just please invite comments on recent popularity of web in bifurcation
Yeah.
place, since we are discussing the classic bifurcation place, Basilar. So web has recently published complications rate the smallest possible numbers of morbidity and 0% mortality. So do you think that web in endovascular regime will become the first choice and replace the coiling?
Ruptured maybe.
Dr. Takiro and Dr. Kuduka, Dr. Satoshi, open for your mouths.
I think it completely depends on the size and the morphology of the aneurysms. And another important thing is, of course, the relationship between the parent artery and the aneurysm. If there's some axis deviation, like the anterior projecting aneurysm, Dr. Inoue presented, putting web devices in that portion would be quite difficult. But in coiling, so putting microcatheter and putting some cord inside the aneurysm could be quite easier because of the ability of the coil to stay inside the aneurysm. So I think even in the intra-aneurysmal flow disruptor era, the role of coiling is preserved. That's my opinion. How do you think, Dr. Ota, Dr. Kaoka?
I almost agree to you that probably the flow diverter or intrasacral flow diverter would be main option for treating cerebral aneurysm. So
Okay.
the number of coiling would be less and less.
But not zero.
Of course, not zero.
So there is an important component, Dr. Kaduke, please. You want to...
Yeah. As for the web device, we have no, not really, only one case experience about web, so I can't say anything about web. But the coiling will be preserved. I'm agree with Dr. Koizumi. Yes.
Right. An important part of our procedures is anesthesia and hemodynamic. So I have had one case when there was an unprovoked basilar tip aneurysm rupture, even before the sheath placement, during the diagnostic phase. So I could see the documented intraoperative unprovoked rupture. So at that time, the blood pressures were little unstable. So luckily, I could document that during the procedure. procedure during the diagnostic part of the procedure. So it was unprovoked. So what are your experiences regarding the blood pressure, and what do you advise for the
We usually perform the embolization of the ruptured aneurysm under general anesthesia, and we ask anesthesiologists to keep the systolic blood pressure and 110 or 100.
Mhm.
Can I share my case? There's one case I need to discuss.
Yes, sure. Just last comments by Dr. Takero and Dr. Koduka before you present your Basilar case regarding the hemodynamical baselines during and pre-surgery.
Nothing.
No additional comment. Thank you.
Okay, thank you. So Dr. Takero, can we switch to Uday's case? He wants to present a quick case.
Okay, sure, please.
Thank you.
Come on, Uday. You can do it. Try again.
It's muting me when I'm sharing my screen.
No, I'm not doing anything. Just share the screen first.
Okay.
Okay, next step.
Did you see the screen?
We can see it.
So this patient is a 30.
Yeah, perfect.
Can you see the
perfect.
basilar?
Go ahead.
Yeah. This patient has come to me. It is a basilar top aneurysm. A 35-year-old male. Is presenting GCS is around 12, and ictus is 10 days. So, and his I can appreciate we can appreciate he has a severe vasospastic basilar. So I need your opinion. What can be done? And he has both PCS rising from the neck and part from the dome of the from the aneurysm also. So right now I've kept him so that we can manage his vasospasm and then we place some endovascular. Any other options? Can you see it? Anybody?
Can you see that out there okay?
Yes, I can see.
He has vasospasm. It's 10 days of ictus, and he has this vessels rising from the aneurysm also.
Uday, it's very
The,
just commenting
okay.
on one view is always a
Yeah, no,
mistake.
but I know, I don't have any issues.
Or the patient is symptomatic, or did you take the
Yeah,
MRI or CT
yeah,
scan?
he had that interpedunculaar hematoma, small. His presenting GCS right now is 12. He's slightly drowsy, and it's 10 days since his ictus.
And is there any infarction due to this
No, no,
vasospasm? No.
no. Right now, no. But he's GCS 12. There's a severe vasospasm in this bacillus.
do you
if the
have
patient
three?
complains no rupture, so I would say wait and see for several days because there is severe vasospasm around the
Yeah.
PCAC laboratory,
Yes.
and
Yeah.
from this angiographic images, we cannot obtain enough information to perform safe embolization. I think. So, what do you think, is or Satoshi?
I'm interested in how about his right contralateral vertebral artery? Is contralateral artery, does it symmetrical or left side dominant? So if the patient has symmetrical vertebral artery,
Okay.
I would think putting another diagnostic catheter also to the right side vertebral artery and perform bilateral vertebral angiography to show more extensively the basilar tip anatomy. I basically agree with Dr. Ota's idea, but I want to get as much as the
Oh,
information as we can at this diagnostic stage.
okay. I'll share with Dr. Atta later. I don't have that other. Okay. But right now, what we have done is we are waiting for the vasospasm period to get over, and
Mm,
then we might take up a stent-assisted coiling later.
mm,
So for vasospasm, do you support intra-arterial treatment and angioplasties in selective cases?
So we have done in last one of a case we were doing with of a bilateral patient with bilateral aneurysm. We are still she's on 14 days and we had to do five sequences of intra-arterial vasodilatation. But here the issue was that we might rupture if we just open
mm,
this.
mm, mm.
If we just do intra-arterial vasodilator therapy or something, we might rupture the basilar aneurysm. That is one risk we are contemplating in this case. DP we are maintaining around 140, 120 to 140 because we have not decided to clip also.
So I would still say that we need a complete angiogram to comment the patterns of quadrant cranial fusion, as Dr. Satoshi mentioned, the importance. So to me, the perforator flow is very good despite the vasospasm in major vessel. That's one thing very apparently distinct in this case.
It looks like laminar flow in the basilar artery. So, as Dr. Koizumi said, we need right side vertebral angiography, I think.
So if right side vertebral angio is good, what are our treatment options and how we can change? What can we do?
I think if I see the clear lateral views and neck, then my preference would be the simple approach to endovascular coiling, especially if the other vertebral artery gives a um, uh, chance to review the situation, and the pattern of perforators are more clear on the lateral images, and neck is um, uh, pretty suitable for coiling. So I would go for simple coiling.
So what can we do about the vasospasm now? Is it better to take him up or wait for the vasospasm period to get over? Anything we can do immediately, or is it better to wait in
I
such
think
cases?
intra-arterial treatment is something I support for vasospasm too.
During,
I would I would I would ask my colleagues comments
please,
on intra-arterial nimodipine.
yes, please.
Dr. Tahiro, Dr. Satoshi, and Dr. Kisuke. Do you have any comment on intra-arterial use of nimodipine and angioplasty of in selective cases?
Yeah, after after putting some coils in the aneurysm, the PTA, the basilar artery, is more safe. Of course, not completed, but I recommend this packing with some coils first, then PTA to basilar artery.
Right.
Okay.
And
Now, yeah, sorry.
yeah, please go ahead.
So I'm just asking, what about this versus? Should we wait for this versus passive to wait, and if it ruptures in between, what?
In a young patient, 35 years old, so having a rebleed and losing that patient would
Yes,
be a
yes,
little more shocking for the whole team. So I think
yes.
giving intra-arterial nimodipine and looking at the possibility of a little better vasospasm, its second week is at the end. So if there is a relief in the spasm, and you could offer at least partial treatment by putting the coils to stabilize the situation. Sometimes when you put the first second coil, you see a dramatic change in the vasospasm. And the other thing I would look into one approach which micro neurosurgeons are sometimes support, that cystotomy and having the less bulk of subarachnoid component leads to the vasospasm. So, like our second presentation, so in ruptured cases, micro neurosurgical approach could release and address that cystotomy and taking off the load of subarachnoid blood could be a possible way forward for a young patient with this.
I was reading an article whether head shaking also improves vasospasm by anticlot lysis. Some people keep a shaker head just below the head and it moves slightly, and that head shaking lyses the clot and improves vasospasm apart from intracisternal treatment and intraventricular treatment also.
Yeah, some decades ago, we often use the head shaking after
Yeah.
putting ventricular drainage, but recently in Japan, no one do that. I
Okay.
think nobody did head shaking.
So in traditional teaching, the neck manipulation by chiropractics can lead to another dissecting problem.
Dissection.
Uh,
No,
I would
it's
be
not a
very
vigorous. It's very gentle. Very gentle. I was reading somewhere
I have no idea
historically.
about this. I have no idea about this, and I don't support this, and I don't think it is going to give any beneficial effect. And I would be skeptical for the causing another problem.
Thank you.
I think with this, we thank all the participants, and there were two excellent talks by Dr. Satoshi and Dr. Yasuki, and I'm very thankful to Dr. Tahiro and Dr. Kesuke Kaduka for their active participation and support. We had an excellent discussion, and I thank you all for your time. And with this, we close the session, and we'll see the next time.
Okay, thank you very much for the whole Japanese contingent. Thank you, Dr. Ota, for putting it together. And thank you, Arthur, for moderating. And we'll see you next time. Thank you.
Thank you.
Thank you very much.
Thank
Thank
you.
you.
Thank you so much. Bye bye.
Thank you.